Well, hello everyone. My name is Juliana Reynolds. I'm a PGY4 resident at Mount Sinai in New York. Um, Here today is also Dr. Ryan Hutton. He's our faculty moderator. And today we have three excellent panelists joining us. They're experts in lymphoma and heme malignancies. So we have Dr. Tao from Mayo Clinic in Arizona, Dr. Robinson from Yale, and Dr. Kumar from UT Southwestern. So we'll hear cases from each of them. They'll be interactive. There'll be some poll questions. If at any time during the presentation you have questions, feel free to enter them in the chat and we'll go through them at the end of each presentation. We're the moderators for today's session. And we'll start with Dr. Tao's case on plasma cell neoplasms.
Great. Thank you so much, Juliana. Really excited to be here. For the medical students considering radiation oncology, I do want to just let everybody know, so grateful every single day that I found this field. I just love it. I love coming to work. I love our patients. Especially our heme malignancy patients, so many of them do really, really well with radiation. We help them. We, help with whatever symptom they may be having, or, cure their cancer with very few side effects. And that's always the goal of the treatment, is to really maximize, the chance of cure, a good outcome, with really as few side effects as possible. We're often very, successful in achieving that. So it's really, really rewarding. And we were just kind of chatting today, for example, I just don't really have such a busy day, just a lot of simulations, the procedures that we do. And, basically today I get to kind of relax, I listen to an audiobook while I contour. And it's actually, just really fun. So every day I feel like I get to learn, I get to teach, and it's super rewarding. Anyway, and so my cases are a little bit more for residents. They can even be kind of controversial or even a little bit challenging for residents. But the good news is that even with the poll questions, there's kind of really no like wrong answer with this case. So just to get us started, we have this is a patient that I saw at my prior institution, a 32-year-old woman diagnosed with a solitary plasmacytoma. This was involving T9, part of the thoracic vertebral body, at the outside hospital. And this was all outside the US. So unfortunately, we didn't actually have the actual images. And also, I didn't do a good job saving the images from my prior institution. But, there she underwent a laminectomy, so underwent surgical decompression, and then had post-operative radiation to 40 gray and 20 fractions, covering, the post-operative site and the hardware. She tolerated radiation therapy very well. I asked her if she, had significant dysphagia or side effects. She really didn't. Maybe just a little fatigue, and got over the radiation, side effects very quickly. And then just kind of a little bit background for medical students, so plasma cell neoplasms can be solitary plasmacytoma, and so that's the only area of disease, the other diagnosis would be multiple myeloma, which is a lot more common, and what we see a lot more often. And so, for as far as her imaging reports, by the time, she ended up seeing me kind of going through the history and what happened after the radiation. So she had a PET CT done 3 months after completion of radiation, still showed this destructive T9 lesion. There was the associated paraspinous mass. It did still extend into the vertebral canal, and then there was persistent SUV uptake, so persistent metabolic activity. So then, they waited, they got an MRI spine about 5 months after, still showing this osseous lesion in T9, asymmetric, and then extension still into the paraspinal soft tissues, just kind of uncomplicated post-radiation treatment changes that they see along the thoracic spine. And then, another PET CT 8 months after radiation showed again this lytic T9 vertebral body lesion, and then slightly increase in FDG avidity. So that still could be due to post-radiation changes, but they cannot exclude any residual active disease. So usually by 8 months after radiation, we expect to see that the avidity trends down. It still may not be gone, but we expect that it's trending down, not going up, slightly. So it's kind of heading in the wrong direction. All the labs, all the myeloma labs, CBC, beta-2 microglobulin, et cetera, all completely normal. So go on, next slide. So she's now here in the US, referred to us in radiation oncology. So what would you recommend? So a little bit concerned that there's, possible residual disease given the PET scan. What would the treatment option be? So, okay, great. Oh my gosh, I'm so impressed. Okay. I mean, again, there's not really like that much in terms of like what is a wrong answer. Um, we can move on. So let's just say, so you guys were really, I think I would have recommended observation as well, but if let's just say, her plasmacytoma involved like a completely different location, and still didn't seem like it was responding well, to the radiation therapy, and you're not worried about normal tissues, you're not worried about exceeding the core tolerance, would that change your recommendation? Would you then consider, for example, reirradiation, if that were the case? No, so good. Okay, I'm glad. This is a more, you know, uh, clear, equal, almost equal distribution of what people kind of would think. And actually, for me, I would say no, this would not actually change my recommendation, to continue to observe, or, continue, actually consider, potentially, systemic therapy depending on, what the next scans show. So I probably would still continue to observe this patient, and we can go over why usually, we don't usually consider, reirradiation as treatment for suspected refractory plasmacytomas. So at MD Anderson, they did a retrospective study. This was a little over 100 patients. Out of these almost 100 patients, 17 had refractory disease. And so that's kind of a good number to know that maybe about 15 to 20% of patients, with solitary plasmacytomas, may not respond to treatment. Um, and so the median radiation dose was 45 Bray. And then 10 patients did have pathologic confirmation that this was residual disease, at a median of about 7 months after radiation. Again, you probably don't want to go ahead and biopsy, and do that, even just, for example, sooner, like 3 months after radiation. You still want to see that, there's continual response. And then about 7 patients did have PET confirmation of refractory disease. And then these patients, were treated very heterogeneously, as sometimes, we're kind of like, we don't really know necessarily what to do, for such a rare entity. So some patients had surgery, only 2 did get additional radiation therapy, and then some patients did start on systemic therapy, even though they did not have multiple myeloma. And then other patients actually did have progression to multiple myeloma and then were treated with chemotherapy. And then 2 patients were observed. Go on. And then, so all the patients who actually received systemic therapy, whether they had myeloma or not, eventually did have a complete metabolic response at the site of refractory disease. The 4 surgery patients did not have any local failures, but 3 of the 4 progressed to develop multiple myeloma and needed systemic therapy anyway. And then of the 2 patients who were treated with reirradiation, they had very, very high cumulative doses of radiation, and still that plasmacytoma did not respond. Even after the second course of radiation, they had a biopsy and it still showed that this was refractory residual disease. Both treated with systemic therapy, had an auto transplant, and both did well with a complete metabolic response. So we can go. And so typically radiation doses for solitary plasmacytomas, anywhere from 40 to 50 gray. If it's a really small lesion, you can treat with even lower doses. And so I typically err toward, because there's not a lot of good data supporting any kind of dose response, I typically lean toward lower doses on the spectrum. And so, local control 80 to 90%. Generally, you just treat, the area of disease and you don't need to, go chasing elective nodes or other areas. The ballpark number is 50% progressed to multiple myeloma at 5 years with solitary bone plasmacytomas, but this is lower for those with extramedullary disease, for example, involving, soft tissues, like the head and neck or lung tissue, for example, that would be 30%. And then a lot of times these plasma cell neoplasms are not the fastest growing. They can be like slow growing and therefore respond slowly on PET CT. Some really can take, more than a year for that SUV uptake to decrease. But if it is biopsy proven, refractory to radiation, usually, repeat radiation may not be effective. So you would consider probably, systemic therapy instead.
Wonderful. Thank you so much, Dr. Tao, for presenting a great case. Are there any questions? And feel welcome to write them in the chat if you'd like.
I'm not seeing any chat questions, but
No worries. Okay, we'll move to, oh, we have one here.
oh yeah.
When do you consider retreating, and if so, to what dose?
No, so I usually would say like we don't retreat. So great question, treat with systemic therapy.
Yeah, and this is a really cool case. It's interesting, right? Because we're always kind of, we think of these as very radiosensitive entities, but if, once in a blue moon, there's some kind of genomic alteration, these things are not radiosensitive, then they're not radiosensitive. More radiation is not the answer. So it's very uncommon, but I think it's a really interesting point. And, we see this in other stuff too, right? Like sometimes you have a lymphoma that's like growing through daily radiation. You're kind of scratching your head. It's acting like a sarcoma. And so I think you have to kind of listen to the biology sometimes. So, are you guys able to hear me? I just got asked by Google if I'm speaking Spanish.
I got the same thing. I was like,
we can hear you.
Okay. All right. Sorry.
But I just want to comment too. Yeah, Ron, I think this is a really good case because this comes up quite a lot. Not, maybe a lot because I do lymphoma, but it comes up a decent amount, right? And I think, the teaching point one, that the slow FDG avidity changes after radiation. I see it a lot with these solitary plasmacytomas. I'm sure you guys too. So I think it's a great teaching point for residents that doesn't mean you have to jump and do something if 3 months or 6 months later it's still there. And then also your point is well taken about, reirradiation probably not being effective if it didn't work. And we'll get a lot of referrals from outside, exactly what you had, like asking, can you reirradiate this? So this is a question even people in the community might get. So I think it was a great case.
yeah, no, and a lot of times, medical oncology would send these patients to me, asking, is this an option? Can you reirradiate? This is still the only site of disease. And, I'll say no. Like usually that's not my practice.
Interesting. Well, thank you very much, Dr. Tao. Now we'll move to Dr. Kumar's case on Hodgkin lymphoma.
Okay. Hey everyone, just kind of an introduction. I know I was introduced, but I'm Kiran Kumar. I treat lymphoma and pediatrics at UT Southwestern in Dallas. I'm also the residency program director there. Very much enjoy teaching, very much enjoy having med students and residents. I met Juliana when she was a med student rotating with us, and she was awesome. And great to see her almost complete her residency training. And so I'll get to the case that I'm presenting. So this is a 19-year-old woman who presents with a painless anterior neck swelling, No fevers, drenching night sweats, unattended weight loss, alcohol intolerance, pruritus, fatigue. Really no other relevant past medical or surgical history or family history, otherwise healthy 19-year-old. On exam, you could see and feel there's this large, palpable right cervical lymph node. Really no other palpable lymphadenopathy, no hepatosplenomegaly, no other abnormalities noted on exam. So rest of workup for her. So you get your lab, CBC, LFT, HIV test, LDH. These are all within normal limits. You get a ESR, which is 61, so that's elevated. And a pregnancy test is done as negative. So they get to some imaging, and they get a CT of the neck and a CT of the chest. And the CT neck shows several bilateral cervical lymph nodes, a lot more on the right than the left, including this bulky mass that you can see both in the neck and the chest. That's what's palpable. This leads to a core needle biopsy of the right cervical lymph node and comes back with the diagnosis of classical Hodgkin lymphoma. 15 and 30 is positive, and you see this classic Reed-Sternberg cell here. Go next slide. And so then we get a PET CT for staging. And so one important point is that there were some lymph nodes that were called on the left neck on the CT, but none of these were FDG avid. They were just mildly enlarged. But in the right neck, as you can see from this coronal, and then also from some representative axial slices, there's levels 2 through 5 FDG avid right cervical lymph nodes. SUV maxes in the 20s, and then 7 by 4 by 6 centimeters is the size they're giving. And then there's this right mediastinal lymph node, and the report talks about it involving prevascular, paratracheal, parabronchial, and that's also decently large in size, 6 by 5 by 6 centimeters in size. Okay, so first is just a question for med students and residents. How would you stage this patient, and what risk group would you give? Okay, great. So good job. Majority of people got this right. So this is stage 2A. So in Hodgkin lymphoma, remember we're still using A and B, and this she did not have B symptoms. And then this is going to be considered unfavorable because of the elevated ESR. Okay, so knowing that, and this is just kind of reviewing some of the staging. So again, stage 2 means multiple sites on the same set of diaphragm. And then if you go to the next slide, I believe. Okay, actually, we can go back. So, and then, whoops, sorry.
Sorry about that.
So no worries. Yeah, so here, these tables, which if you're a resident and you've been on lymphoma or if you studied lymphoma, you've probably seen these a handful of times at this point, kind of help us classify things as favorable or unfavorable. And some of the teaching points are that there's different risk groups, right? There's German Hodgkin Study Group, there's EORTC, NCCN. And so most of the time when I'm teaching my residents and med students, I say you probably focus on the German Hodgkin Study Group and the criteria on that makes something unfavorable. For all of these, if you have an elevated ESR greater than 50, you'll be unfavorable. So per all these criteria, she's unfavorable because of the ESR. There's also the number of nodal regions, and in that red box, the big differentiator for German Hodgkin is that if it's greater than 2, then that becomes unfavorable. And then on the right, you'll see the sites, because what is considered one site is different based on these different criteria. And so this is just for your review, but we can go to the next. Okay, so here is the interesting question that I'm curious about. How would you treat this 19-year-old woman with 2A unfavorable Hodgkin lymphoma and the distribution that you saw? Okay. All right. So, there's really no wrong answer here. So all of these are kind of possible treatment choices, right? This is 19, so the choice D would be kind of treating the AHOD COG way down the pediatric protocols. C would be treating like a German Hodgkin unfavorable, how they do over there with the 2+2 chemo. A and B, which were the choices that you guys picked, are probably the two most common choices here in the US and how we treat these patients. And so let's talk a little bit about this. If you go to the next slide, we'll review. So, this is very brief. I'm going to, go through this quickly, but just to review the major studies for early stage unfavorable Hodgkin lymphoma. We'll start with a few of the German Hodgkin studies. So this is HD11. So in this study, they looked at ABVD versus BIACOP. So one of the questions that was randomized was the chemotherapy. And then another question that was randomized was 20 gray versus 30 gray of IFRT. This is pre-PET era. It's a 2x2 study. And basically, the ABVD times 4 plus 20 gray did worse, and the other three arms all did similar. And because there was no significant difference, the standard of care continued to be what we still would say is the most common standard of care, which was ABVD times 4 and 30 gray. And if we go this slide, so the follow-up study for this was HD14. So it took the standard arm, which is ABVD times 4 and 30 gray, and compared that to this 2+2 chemotherapy. So 2 escalated BIACOP, 2 ABVD, and then 30 gray radiation. So this also is pre-PET, so we're not using PET to guide therapy. This study did find an improvement in progression-free survival with the escalated chemotherapy. There was no difference in overall survival, and so this is one of these things that can be interpreted in multiple ways. And so, in Germany, where they're using this 2+2, they are, saying that, hey, it's improved PFS, so we're going to say that this is better. Here in the US, we say there's a lot more toxicity with BIACOP, and there's the same overall survival, so we're going to stick with 4 ABVD and 30 gray of radiation. This study is the newest one in the PET era, right? So this is taking this 2+2 chemotherapy, so 2 escalated BIACOP, 2 ABVD, and looking at PET response and seeing if we could de-escalate therapy for those who have a complete metabolic response with a very strict definition of a Duval 1 to 2. And so if you had a complete response after chemo with the Duval 1 or 2, these patients are randomized to 30 gray of IFRT, which was the control arm, and then observation, which was the experimental arm, seeing if they have a complete response, can we omit radiation? And this is really the only, large randomized study in early stage Hodgkin that actually found omission of radiation as especially after just 4 cycles of chemo, as being safe and not having a detriment in terms of PFS. You can see these arms are the same. And so I always say that if you're really trying to avoid radiation, one of the options is this 2+2 chemotherapy. And then if they have a CR, you can avoid radiation. And then the question, you guys picked A and B as the most popular answer. So one question is one better than the other? Is doing 6 cycles of ABVD or 6 cycles of chemo better, worse, or the same as ABVD times 4 and 30 gray of radiation? The answer is we don't really know, right? You can debate it. There's a lot of data. There's a lot of stuff you could argue one way or another. EORTC H10U, which was the unfavorable arm of the study, so which this patient would have qualified for, has some data that may help answer this question. And so in this study, patient who had the control arm was 2 ABVD, they got a PET, and regardless of response, they got another 2 ABVD. Then just of note, in this study, they used INRT, which is involved nodal radiation. The experimental part was if they had a CR after 2 ABVD, they just got 4 ABVD, so 6 cycles total. So this is kind of looking 6 cycles versus 4 and 30. And if you look at the intent to treat or the per protocol, there was no significant difference in 5-year PFS or 10-year PFS. If you look over at the per protocol on the right, 91% for the radiation, 86, but the p-value is 0.16. So maybe is trending towards favoring radiation, but not significant p-value. So all intents and purposes, we can say they seem similar. Go to the next slide. And then lastly, if you are going to treat with 6 cycles of chemotherapy, so if you're going to go the chemo alone approach and try to avoid radiation, do you need 6 ABVD? The RATHO trial tells us no. If you do 2 ABVD and you get a negative PET, you could drop the bleomycin. So the last 4, you could just do ABD. And these people did equivalent to the 6 ABBD. So that would be kind of the standard of care if you did chemo alone. Let me go to the next slide. Okay, so what did we do for her? So she got 2 ABBD, and then she got a PET CT to assess response. And it came back as a metabolic complete response. They gave it a 3 in this. And so it was actually interesting. This is someone at tumor board where they, it's a 19-year-old girl. You're treating upper mediastinum, you're treating neck. Most people would just automatically think, hey, we should just do chemo alone, right? These are the people that in Hodgkin lymphoma jump to your mind, like, don't radiate, you're worried about breast, you're worried about heart. But this is one of these things where it's always good to just actually review the imaging and review the anatomy at tumor board. We kind of looked at it and we're like, and one, she also was not tolerating chemo well, even though she's 19, she hated it. Looked at it and said, hey, maybe it'll be safe to treat her with radiation based on the distribution of the techniques that we have. So that's what we ended up doing, and we can show you that next slide. So how did we sim her? So there's different ways of simming. So as I kind of just talked about, the main things we're worried about in Hodgkin lymphoma are long-term side effects, especially secondary malignancy, so breast cancer risk in young women, and heart, cardiovascular disease. So these are 2 structures we're trying to do everything we can to avoid. And so, they have these incline boards. This is a picture that from MD Anderson, or especially if you have larger breasts of women, if you incline them, it could kind of help them fall down and away from where you're treating. In this case, since I was treating the neck, I had a long mask, and you could actually use the mask to physically push the breast down, like inferior and lateral, which we did to help move them out of the way. And then for the heart, deep inspiratory breath hold, there's various ways of doing it. We have Vision RT, so this is surface guided radiation to do a breath hold, which will push the heart inferior and posterior away from our target. And here's just some data showing why deep inspiratory breath hold can be very beneficial. You're seeing a pretty significant difference in mean heart dose. It depends exactly where the disease is. So it's not always better. So we will always do a breath hold scan and free breathing and see. But often in this area, you'll see a pretty big difference. And then there's different treatment planning techniques, right, to help reduce the dose of the breast. And so some of you may have heard of this butterfly technique, which is an IMRT or VMAT, where you're basically bringing 5 to 7 total beams with a few non-coplanar arcs. That's really trying to weight the distribution. You can see on the right, mostly APPA, and trying to avoid lateral spread of dose, because we know low dose can cause secondary malignancy and breast cancer. If you have the ability to do that and to do non-coplanar, it's a great option. Go to the next slide. And here's some of the constraints just for your reference. So this is in the NCCN Hodgkin lymphoma. Just know that in Hodgkin lymphoma, we use much stricter, and any lymphomas, we use much stricter constraints, right, than other disease sites. And so I highlighted some of the ones we care about here: salivary glands, a mean less than 11, heart, mean less than 8. Go next slide. And then for breasts, you really want to minimize the volume of breast tissue that's getting 4 gray or more. Okay, so let's get to the end of the case and to our plan. So here is some slices of our plan. So this is showing you, the coronal is kind of showing you an overview, and you could see that's the 5 gray isodose line in light pink, and you can see how that's, well, fortunately, the disease is all superior to the heart, right? And so we're actually able to stay very sharp, soup in off the heart. And then on this axial, we're in the head and neck area, and the 11 gray isodose line is turned on there because we care about a mean less than 11 for all of these. And so you can see, even though you have disease very close, with the proper planning techniques, you can really carve around, obviously contralateral side, but even the ipsilateral submandibular, the mean was very low. That was 7 gray, contralateral was 3.5 gray, oral cavity was 1.7, stay off the midline. Thyroid is something in the lymphoma world we look at, and when possible, we try to avoid. And if you go to the next slide, and then this is probably, this and the next slide will be the most important. So for this one, we're looking at the heart. So you can see on the sagittal, another view of how we're coming off the heart. And so in this case, just with deep inspiratory breath hold and proper planning, we were able to get the mean heart of a 1.3 gray. and the V8 was 1.5%. The V15 was 0.4%. So this is something that we felt very comfortable doing, and just felt that would have minimal risk of any cardiovascular issues. If you go to the next slide, and then breasts. So this is the other thing. So, this patient was treated on a machine where we actually could not do non-coplanar, but even with coplanar, with the proper pushing, you can carve around breast tissue, right? And so we really tried to keep our 4-gray acidosis lines. If you look at the left breast, the mean was 0.4, the right breast, the mean was 0.8. But really, the left breast, the max was 3.6 gray, the right breast was 5.4 gray. And so I think if you push it, yeah, there's trade-offs. You can see there's more 5 gray kind of spreading lateral now through the lungs. But I think the breast, everyone would agree with the priority of the lungs over low dose to the lungs in this case. Okay, and then just to kind of summarize the case here, so what are the interesting teaching points or challenging aspects? Really, this question of chemo alone versus combined modality and Hodgkin lymphoma, early stage Hodgkin lymphoma, you could spend hours debating this and talking about data. It's very interesting. I think it has to be personalized. I think the radiation oncologist should be part of that decision making, which it always isn't, because you can't just categorize and say these patients you should always avoid radiation or these patients you shouldn't. It just really has to be done based on the anatomy and where you're treating. If chemo alone, there's a lot of options, which one is best, and that's also something interesting about this. And then I thought it's just good to see these classic mediastinal lymphomas for simulation treatment planning techniques on how to avoid stuff, especially the breast and the heart. And then finally, yeah, I didn't get into protons, but protons, there are this distribution. I don't think it would have made much of a difference, but if they had disease in like the axilla and you're trying to avoid the breast, or if it's lower down near the heart, or you have something posterior, there could be various disease distributions where protons could be significantly beneficial. And then really follow up 3 months later, got another pet. She's a Lugano 2. She's 4 years out, no long-term side effects. She had some mild esophagitis during radiation, no other acute radiation side effects, no long-term side effects. She hated chemo, so she was like really happy to do this and not do 2 more cycles of chemo. And then there's always the surveillance. Despite very, very low doses, still would have to do the recommended surveillance of mammograms and echoes and carotid ultrasounds.
Thank you, Dr. Kumar. That was an excellent case, and I'm glad to hear she's doing well now. Any questions for Dr. Kumar? You're welcome to type them in the chat.
No, this is such a great case. Him and I just finished the ABR oral board exams, and I think this case highlighted so many concepts that sometimes candidates get a little bit confused. So just to emphasize, for example, a lot of these patients, with mediastinal lymphomas, we do really favor DIBH, and it's not like I think a lot of people kind of confuse it with concepts for motion management. Yes, it helps. That's kind of like a secondary, but you don't want to usually just go with free breathing 4D, not because of, maybe there's a little bit of excess motion and you have to contour like a little bit of an ITV. But it's really, for some patients, it's really the anatomic changes with taking a really, really deep breath. Similar to why we do DIBH for left breast cancer. It's like you want to take advantage of the anatomy, expand the lungs so that the lungs are really, really inflated and you treat more air and not lung tissue, but also more importantly, that it really helps displace the heart, away from, where you're treating, especially, the superior portion of the heart where the proximal coronary arteries are, your most important organ at risk. A few millimeters of displacement with DIBH can actually make a huge difference in the dose distribution for your plan.
Yeah, and I was just going to echo that, even outside of the heme world, I had a patient with a metastatic prostate cancer that was recurrent in the sternum, and it was in the lower half of the sternum. And actually the medical oncologist was like, no, you can't get radiation. This is right on top of the heart. And that was true for the free breathing PET scan. But then with the DIBH, it was completely separated. There's essentially no dose to the heart. So you get to kind of bend the rules a little bit with the DIBH. It can be very helpful for dropping the heart down away from the chest wall. I also just dropped in there, I think this is a great talk, Kieran. One thing I think is interesting we don't think about is that I put in the drop, there's actually a study that's showing that, oftentimes we think about radiation causing breast cancer and it's a real issue. but actually cumulative anthracycline dose has also been associated with the risk of secondary malignancies and increased risk of breast cancer. So it's not zero with chemotherapy. And so, you know, I think if you run the numbers, I think they get around 200 mg per meter squared total anthracycline. So they kind of hit that threshold. So I think it's just, you know, maybe a future study will look at that. But I do think it's interesting that it's not zero even with the chemotherapy.
No, and that's a great point. And I think also a lot of times medical oncologists will like be worried about a 60-year-old woman and they'll be like, what about her breast dose? Oh, I'm like, well, you know, there's actually data showing that, you know, when we give radiation when somebody's actually older than 30 or, you know, 35, it actually does not increase the risk of breast cancer. So that's especially the case for a postmenopausal woman. Generally we consider the worst time to give radiation is during puberty, you know, in the teenage age. That does increase the risk of breast cancer, but really when patients, you know, are older than 30, that risk is, you know, significantly lower. And then especially with modern radiation techniques, you know, studies have shown that actually, you know, as long as it wasn't mantle field radiation, you know, the patients didn't actually have any increased risk of secondary breast cancer compared to patients treated with chemotherapy alone.
Yeah, I think that's great points. Tim, thanks for sending that article. I think that's great. And kind of similarly, the long-term results of H10 got published not that long ago, right? Showing no difference in secondary malignancy between the chemo alone or the chemo and radiation arms. So I think these are all important points with modern planning that you have to think about real toxicity of more chemo versus radiation.
Thank you
Looks
so
like there's a
much.
question.
Ross.
Looks like there's a question in the chat, I think.
Ah,
Yes, let's see. I can read this. So, when planning radiation for bulky tumors, how do you define the post-chemo target volume? Great question. And so, you know, I didn't get into the details of ISRT, but this is all involved site radiation therapy. There's some very great ILROG guidelines on the internet that will help show cases and contouring. But really, you take the pre-chemo volume, but then this thing is gone, or it's mostly gone. There might be some soft tissue remnant, so you have to heavily modify it for what it looks like on your CT scan. And so usually you're cropping off of, like in this case, the lungs and other stuff that's kind of fallen and changed, and it ends up being not too large of a volume. But there's just if you just look up the ILROG guidelines for ISRT, there's a lot of great resources out there.
Cool. All right. So I guess I'm up next. And Juliana, are you advancing the slides?
yes.
Okay, wonderful. Thank you. Yeah, so feel free to interrupt in the chat if you will. But my name is Tim Robinson at Yale. And Rhonda, it sounds like I need to come work where you do. So no, it's all right. So first case, initial presentation. So this is a case actually I saw very recently, 73-year-old male who presented with abdominal pain and left lower extremity edema. Got an ultrasound that was negative for DVT and then found to have inguinal lymphadenopathy. Got a plain CT shown here. And you can see this on the left-hand side, this kind of large left-sided pelvic wall mass concerning for malignancy. Go ahead, advance. And so this led to a workup with a PET CT. So the first question is probably going to scoot your little pole thing to the side and just take a quick look. So again, from what you can see on the PET scan, you know, what stage would you guys consider this to be? And you'll see on the axial slices, you've got, you know, at the head and neck area, there's some node involvement. And are you guys able to see my mouse? Yeah or nay? Probably not. That's fine. In the middle second slide, yes, you've got axial lymphadenopathy, and then down bottom, you've got pelvic. So all come within the lymph node basins. Okay. So let's see the results of that one. Yeah, so good. A good spread. So this means that either people, yeah, good. This is stage 3. So the way that we do staging in lymphoma is this NR staging. And it's actually not bad. All right. So if you've got one site of disease, you've got stage 1. If you've got 2 sites of disease, you've got stage 2. And then if you have disease above and below the diaphragm, that is stage 3. And stage 4 disease, I think of as, quote, kind of metastatic, right? So what does metastatic mean for lymphoma? So in my mind, metastatic is disease, you know, the home base of lymphoma is the lymph nodes. And so if you have disease that is above and below the diaphragm, but remains within the lymph nodes, that's still stage 3. But if it metastasizes to the bone marrow, to multiple sites of extranodal areas, bone, whatever, or even if you have nodal and extranodal, really it's kind of metastasized. And that's why I think of kind of stage 4 disease. And so there's kind of a little nuance. One other thing I'll mention that I think is just kind of a hang up that was great with Hodgkin's disease is sometimes we talk about, regions versus areas, and there's this confusion, especially in Hodgkin's when we're trying to assign risk. So I strongly encourage you to check out the Hodgkin Study Group website. They have this beautiful page in German. And I think of, regions, regions are really small and there's multiple of them. Use that for staging. But areas are for determining aggressiveness. So favorable versus unfavorable, and they're huge. So anyway, just a very clear distinction. If you're doing favorable, unfavorable, number of sites, that is an area. Those things are big versus regions shown here, which is much smaller. All right, next slide. Yes. So the question is, what else do we need to do? So right now we have stage 3 according to the PET. Is there anything else we need to do for this patient with diffuse, well, we haven't said diffuse large B-cell lymphoma yet. But yeah, anything else? We'll say just if this was diffuse large B-cell lymphoma, is there anything else we need to do to complete staging? So do we do nothing? Is this good enough? Are we done? Or something else? So what do we get? Yeah, so bone marrow biopsy, right? So this is another kind of sticking point where, do you need a bone marrow biopsy, right? And the kind of confusion becomes between Hodgkin's versus not Hodgkin's. I think of Hodgkin's. So Hodgkin's disease was discovered back in the 1800s, and they initially thought it was a form of tuberculosis, right? So they thought this was an infectious disease. It was these giant lumps kind of spreading out of the neck and spreading locally. It's a much more localized process, whereas diffuse large B-cell lymphoma, even though the diffuse part refers to its appearance under the microscope, it really does kind of systemically behave diffusely as well. So it's much more likely to spread to other places. And not only that, with diffuse large B-cell lymphoma, oftentimes these are a result of transformation from lower grade lymphomas and follicular lymphomas, and those may not have a high SUV uptake. And so for that reason, whenever you're dealing with either a diffuse large B-cell or a follicular lymphoma, any of these, those kind of non-Hodgkin's disease, you want to get a bone marrow biopsy to make sure there's not disease in the marrow or follicular disease in the marrow, because if there's follicular disease hiding out, that's an incurable patient. They have a long-term issue. In contrast, in Hodgkin's, again, it's a much more localized process. They've done studies in patients with, localized disease, nothing abnormal in the counts, blood counts, nothing abnormal in the PET scan, in the marrow. They've seen 700 patients, you'll have 1 or 2 of them that have actual bone disease. So when you do a bone marrow biopsy for Hodgkin's disease that doesn't have any obvious evidence and it's low risk, you just don't need to do a bone marrow biopsy for those Hodgkin's patients. You always do for these diffuse large B-cell non-Hodgkin's. All right, so next. And then just for clarification, MRI brain and CSF, of course, that's when you're talking about a patient with testicular involvement, you're worried about occult CNS. All right, so this is a stage 3 diffuse large B-cell, and they've got an 11 centimeter left pelvic mass. So what do you use for like bulky disease and diffuse large B-cell lymphoma? So here's some different cutoffs you may have heard in different settings. Go ahead and choose one and we'll count it up. What's bulky? Aha, whoa, hot dog. Okay, good. This is fantastic. Yeah, so 7.5 is definitely what I use. And I think kind of a broader take-home lesson here is that, again, we're talking about lymphoma today, but no matter what medical field you go into, it's always nice to kind of couch, why you use 7.5. And of course, a very nice answer is a Recover 60. If you click, we'll have a floaty thing, I think. Yep, oh, there it is. So yeah, the Recover 60 trial, very lovely trial where they tried to get rid of, this is pre-PET era, basically older folks over age 60 getting R-CHOP, and they treated everybody with tumors that were bulky as defined as 7.5 cm. And when they got rid of that radiation, patients had about double the risk of progression. And so that's why 7.5 in my mind is kind of a nice diffuse large B-cell. It's a relevant dose based on the data. All right, so next one. So this one, so which of the following is a double hit lymphoma? And so this is a little bit nuanced, but it's because, again, we just did the oral boards and I found this extremely irritating. So the next generation is going to do better with these nuances. So is it MYC and BCL2 overexpression by immunohistochemistry? So looking just, on a past slide. Is it MYC and BCL2 mutations or deletions? Is it BCL2 and 6 rearrangement by FISH, or is it MYC and BCL2 rearrangement by FISH? So which of these can be considered a double hit lymphoma? All right, what we got? Aha. Not bad. Yeah, so the bottom answer is correct. So the key thing, go ahead and click again. And the key thing is, yeah, Giuliani, if you click for the animation, we'll see what happens. There it is. The key thing is that it's rearrangement, right? So rearrangement means a chromosomal rearrangement. The DNA has been moved around, and FISH is how you detect those. It's not mutations, it's not deletions, it's not overexpression. There's been studies looking at double overexpressors, and it's kind of intermediate, not really compelling. The data is not that great, but really you're talking about rearrangements by fish. And the key thing here is MYC is an oncogene that makes these things, it's like a rocket engine, right? So MYC-based cancers like Burkitt's lymphoma, these things grow like stink. So MYC is kind of the rocket engine, whereas BCL2 is this anti-apoptotic kind of like armor. So if you've got like a rocket engine and armor, that's when you've got these really gnarly tumors. So again, you have to have both MYC rearrangement and either BCL2 or BCL6, but really nothing else counts. So if you have BCL2 and 6 rearrangements, doesn't count. And then nobody actually cares about mutations or deletions or overexpression. Those don't really count. So again, a rearrangement of MYC and one of these two. So you need a rocket and armor. So we've got a patient, we'll say the bone marrow biopsy was negative. So stage 3 diffuse large B-cell lymphoma. Here's kind of our 4 treatment options. You can get away with 3 cycles of R-CHOP, followed by evolved site radiation. Or do we need 4 cycles of R-CHOP and then that's it? If no, if it's PET CR, we're done. Or do we need 6 cycles? Or do we need dose-adjusted R-EPOC? So what do you think here? That's right. Excellent. Okay, good deal. Yeah, so 6 cycles. Yeah, so for advanced stage disease, 6 cycles of R-CHOP, PET CR, you're good. The circumstance in which you might use dose-adjusted R-EPOC, so I just mentioned this cytogenetics. If you test for the double hit lymphomas, usually we treat those with something more aggressive, and dose-adjusted R-EPOC is kind of a very common regimen that's used for those, because those things are pretty gnarly, so they need kind of higher dose chemo. Or if you're dealing with a primary metastatic B-cell lymphoma, again, those do better with dose-adjusted R-EPOC. Option A, 3 cycles with involved site. That's for kind of early stage disease, stage 1, stage 2. And then option B, 4 cycles of R-CHOP. That's for a very favorable early stage, kind of if you've heard of the FLIER trial, patients can potentially get away with 4 cycles if they have very favorable localized disease. All right, next slide. So the reason why, so here we go. And here is patient's disease. So the pre-chemo is on the left, and then the new one's on the right. And just the arrow is pointing to this area on the left. So they've got complete response to disease that's all gone except on the left pelvic sidewall. And that area shows uptake that's just above liver. And so what would you consider the Deauville score for this patient overall? So this is what response looks like. What Deauville score is this? What we got? Right. Yeah, so it's a Deauville 4, right? So this is why I chose this case, because it looks really good, but that's still a Deauville 4. What do we do here? Okay. And so go to the next slide. So what do we do? All right, so I mean, this is a Deauville 4. I thought that was positive, right? So this is primary refractory disease. It's immediate. We need to go directly to CAR T as A. Or this is primary refractory disease, proceed to autologous stem cell transplant. C, good enough. This is a complete response. We don't need to do anything. Or this is a near complete response. Let's do focal radiation to that area with the residual 4. Or we think this is a near complete response. We better consolidate everything. So those are kind of your options. How would you manage this case? Okay, what we got? Yes, good. I'm glad to see that. I didn't even give this talk, which is great. So next slide. So the key thing here is that yeah, and then so the next question is, what dose would you give? So I'll go ahead and let you guys kind of think of what dose you would give in this situation. So Deauville 4, everything's gone away except for one side of disease. There's your choices, and we're good. Okay. Yeah, very reasonable. So I think, 36 grade plus, I think 40 to 45 is pretty standard. But I think 36 is a hard minimum in this situation. And I don't know that you need to go to 46 plus. I mean, it's, I think in the 40 to 45 range. We haven't established the exact right dose, but I think, again, just kind of more than your usual consolidation is what I would recommend, or what I would use in this situation. All right, next slide. And so the reason why I like this chase is because I've had this even come up even at one year at the oral boards, and it was kind of, we're discussing these cases, and it was just like, oh my gosh, it's a patient's the Deauville 4, and it's kind of like, oh, do we need to sound the alarm, right? And so oftentimes we think of kind of black and white in terms of PET response. So a Deauville 4, we think that's positive. And I think a key thing is remember that the Deauville score is a qualitative assessment. And in certain circumstances like this, a quantitative assessment can be a lot more informative, even though we don't use those nearly as much. And I think, again, for these cases, you really want to know how to recognize true relapsed refractory disease versus near complete responders, because the management is dramatically different. We were talking about CAR T therapy for $400,000, you know, and possible risk of Guillain-Barré-like neurotoxicity. We're talking about autologous stem cell transplant with a small single-digit mortality, but a potentially 10% risk of long-term MDS later in life that can be life-threatening. You know, these things, those are not small potatoes. So those are very serious. You know, those are really escalatory ways of managing. And this is a place where, as radiation oncologists, I think we can kind of help provide a voice of reason of managing this less aggressively. All right, and I think I've got 1 or 2 slides left for the kind of epilogue. So how's this patient going to do, right? All right, so we have this patient, they have one area, and the question is, compared to other patients with advanced diffuse large B-cell lymphoma, are they going to kind of look basically like somebody who had a completely negative end of PET scan? Is it going to be more similar to somebody who had diffuse progression, or somebody who had kind of a clear focal progression of true relapse disease, but just focally? How do you think their outcomes are going to kind of behave overall? Go ahead. Yeah, exactly. That's exactly it. So there's a lot of studies looking at this. I didn't have time to go into, but the key thing is that for these patients with kind of just, you know, a quote positive PET scan, but it's just, you know, have a really good response otherwise, you can do focal consolidation, and those patients do very well, minimal toxicity, and get to sail off into the sunset. And I think that's all I have. Great.
Great. Thank you so much to our wonderful presenters, Dr. Tao, Dr. Kumar, Dr. Robinson. Thanks for taking the time to be with us. If anyone has any questions for Dr. Robinson, feel free to write them or. Okay, we have one.
I think it's false alarm. I think that's just somebody being nice.
Well, wonderful. These were great cases, and we appreciate everyone's time so much. So thanks for being with us. And our next ROVER session will be on June 6th. So stay tuned for more information. Thanks, everybody.
All right, guys.
Yeah,
Thank
great.
you. Thanks for having us.
Bye.
Thank you.